Recording from the Sunshine City, St. Petersburg, Florida, overlooking beautiful Tampa Bay, this is the Sonography Lounge, sponsored by Gulfcoast Ultrasound Institute. This podcast is dedicated to medical professionals and patients around the world interested in diagnostic and interventional ultrasound. Our podcast will discuss everything ultrasound, from news, trends, career paths, new technology, and industry updates. Hosted by Lori Green and Trisha Rio of Gulfcoast Ultrasound Institute, they bring over 4 decades of experience in the ultrasound profession and are here to guide you through this journey. Now sit back, relax, and enjoy.
Hello, everyone, and thank you so much for joining us today on the Sonography Lounge, where we talk about all things ultrasound. I'm Trisha Rio. I'm happy to be here today in the lounge with my co-host, Lori Green.
Hi, everybody.
As you guys can tell, we have a new setup. So this is our brand new studio after we relocated our offices, and we love it so far. So again, thank you guys so much for joining us. In the Sonography Lounge, you know we all love to dive into our technologies, clinical strategies, and industry leaders shaping the future of ultrasound. And today's episode is a very important one because we are talking about 2 areas that are rapidly growing in relevance, but still surprisingly are underutilized in the outpatient care. We're going to be discussing some peripheral vascular physiologic testing and transcranial Doppler, also known as TCD, in the cardiovascular and diagnostic center settings.
That's right, Trisha. And as practices continue to see more complex vascular patients, and the push for early detection and precision diagnostic grows, the need to have reliable, non-invasive tools has never been greater. Physiologic vascular testing, such as ABIs, segmental pressures, pulse volume recordings, offer crucial insight into arterial and venous health long before disease escalates. And TCD brings a unique window into cerebral hemodynamics, empowering clinicians to identify stenosis, vasospasm, microemboli, and impaired autoregulation without ever sending the patient to the hospital. But here's what makes today so unique and exciting, because we are joined here today with Michael Talcott and Staten Hoover with Image Monitoring USA. They are a leader in bringing advanced vascular and neurovascular testing solutions into outpatient centers across the country. Michael and Staten have been instrumental in helping practices integrate physiologic testing and TCD into their workflows, not just from a technology standpoint, but also from a clinical, operational, and financial perspective. So welcome. Thank you for joining us today.
Thank you. Thank you for having us.
Yes, we're very excited to have you here. So Michael and Staten have seen firsthand how the diagnostic tests that we're going to discuss today can elevate patient care, but also can expand service line and strengthen a center's ability to detect disease early while also keeping those tests accessible and affordable for their patients. So in this episode, we're going to unpack why these modalities matter, why they're important not only to the patient but to the clinician, how they can be seamlessly implemented, what challenges clinics have faced, and the surprising opportunities many outpatient centers are missing. And with their experience guiding our conversation today, you'll get a front row look at where vascular and neurovascular diagnostics are headed. So let's dive right in.
Yeah. Thank you for inviting us.
Yes, thank you again for being here. We're really happy. So just a side note, we just closed out a cardiovascular scanning skills workshop, and these 2 gentlemen were pivotal in the success of that for those participants who did the peripheral vascular track by bringing in their system, the Falcon Express, where they got to experience firsthand what it was like to do some of those physiologic tests on the patients. So thank you, gentlemen, for your equipment support. We're always so grateful for everything you do for us.
Well, thank you for having us.
Yeah, very welcome. Thank you, and we're happy to contribute.
Yeah, I think the participants were really happy to have you here, too.
Yeah,
so.
They are.
Definitely.
Yeah, absolutely. We certainly appreciate all of your support, and our learners are really appreciative of it. So it's a great relationship that we have.
It certainly is, because, in the world today, there's so many people that don't have the education on how to do testing properly.
Mm-hmm.
I see a lot of people that have learned from one person that learned from another person that learned from another person. And just like anything else, a lot of information is lost. And unfortunately, the patient can suffer because of that as well, because we don't diagnose it as accurate as we should. So I really appreciate what you provide and what you bring to our community. It's definitely helps everyone to get the most out of not only our equipment, but the most for the patient for accuracy. So thank you.
Absolutely. You're welcome.
Yeah. happy
Quality
to
of
do it.
patient care. That's where our mission is, right?
That's right.
That's right.
That's right.
So let's go ahead and get started and lead into that and the discussion here and talk about if you've seen any significant changes in the way hospitals and outpatient hospital patient testing has changed, particularly since COVID.
Thank you for asking. That's something that was significant in all of our lives, and it affected the way we did things and still do things in our practices. And the thing that I noticed is that we lost, I would say, at least 20% of our technologists during COVID.
Yeah.
The workload that was presented to everybody and the stress that we had a lot of people, just like physicians, just decide that they had had enough. And so now we're working with 20% fewer people than what we had at that time, pre-COVID. And plus we are already down about 20% of the pre-COVID of what we needed for technologists, because it is a high demand market. We have a definite need. So that's the biggest change I've seen, is that everybody is just to the maxed busy. They're maxed out at their lab. So they're looking for ways to do things much quicker, but diagnostically accurate and efficient. So that's why we've seen physiologic have a resurgence, not only at the hospital level, but also they're asking the physicians to start doing more quality testing versus screening. And we all know those systems out there that are screening units that it's a crapshoot on whether the data is correct or not.
Right.
And a lot of times it's because of ease of use that people are going towards that direction and using those devices. But unfortunately, the patient sacrifices, the doctor that's doing the intervention sacrifices, because they get patients on the table that may not have any disease when that device said they did.
Okay.
And so we're seeing a lot of hospitals that have realized that the devices that they had purchased just were not accurate to the level that it could be or should be. And so that's why they asked us to develop a Falcon system, because they had our Falcon Pro. They wanted something as accurate as a Falcon Pro, but in a more economical system. And they wanted something that was very automated. And so that's what we've come out with our Falcon Express series, much more economical. You've got systems from $22,000 all the way down to $12,500. So very economical, so we can meet everybody's need. But yet we didn't sacrifice on the technology. You still have spectral Doppler. You still have auto inflation, calibrated PVRs. You've got PPG. You've got everything that you do on the Falcon Pro, just a little bit more work to do on the Express to save funds.
Right.
And then on the TCD front, we've also noticed that a lot of people are asking to do TCD. But again, our biggest problem is lack of technologists. And that's where you come in and hopefully can help alleviate that over time.
Right. Yeah. Yeah, I would say COVID definitely hit our industry very hard. I mean, healthcare in general, but ultrasound was kind of already struggling. And then you take that and they're put into situations where if they were in outpatient imaging, now all of a sudden they don't have a job for 7, 12, 15 weeks. And then they're just supposed to come back. And it's like, well, they went and found other things to do with their time and their skills during that absence while those centers were closed. Or if they were working in a hospital situation, they were required to do things that maybe they themselves weren't willing to do and then walked away from the field. So it's definitely presented a very unique situation to our industry as a whole, healthcare as a whole, and we're left to fill those gaps. And it's just nice that we still have such passionate people all across the fields. I mean, I've met them at meetings and in classrooms and everywhere that are just pushing things forward regardless of all the challenges we've faced. So
Absolutely.
yeah,
There is a definite shortage in the
terrible.
ultrasound industry of experienced sonographers. So there definitely is a learning curve there for those people who have not been exposed, especially to physiologic testing or transcranial Doppler, and your system also provides an opportunity for physician practices to integrate that into to offer another service that they might not be offering now that can help to get their patient diagnosis quicker and then ultimately to treatment quicker rather than waiting to have to send them out to a vascular lab or radiology department or neurovascular department to get the full blown test done. They
Right.
can get an answer pretty quickly and know exactly where to go immediately. And at the same time, it's a revenue generating, test for them as well. So it expands their services they can offer. So
Oh, most
it's
definitely.
great.
With Physiologic, you can have a MA trained to do the study.
Exactly.
And you want to make sure that you're doing the same quality of testing that would be done in a vascular lab.
Yeah.
And so coming to a institution like this, Gulfcoast, getting the training on how to do it accurately, and or having a trainer come to their facility and do it accurately, it's very important. And as you mentioned, the physician be able to generate revenue from that, most definitely. Because if we are the doctor diagnoses a patient with PAD, and it's not significant enough to have an intervention, that patient is going to be coming to that doctor every 6 months or a year to have a follow-up physiologic done.
Right.
Each time that patient comes back in, then you're going to do an ABI with Doppler waveforms, PVRs, change possibly the treatment strategy, or perhaps you're helping that patient put them on an exercise program. And by doing that, you're increasing flow and increasing the likelihood that that patient won't need an intervention.
Right.
So,
Yeah. Sorry, a mascot just joined us.
Yes,
Everybody, this is
Sure.
Lola.
Lola,
Lola.
Lola.
Yes.
But to add what
Yeah.
you were saying, it is amazing, even years later, that there's such a shortage with staff.
Yeah.
Because being in the ultrasound departments firsthand, they're overwhelmed.
They
don't have
are.
enough people.
Well, and how are you supposed to attract people to a profession when that's how everybody's working?
Yeah.
right?
Like, it just doesn't seem desirable.
And
But-
it's sad that some departments can't expand into
Right.
TCD because they don't have a technologist
Yeah.
that knows TCD.
Yeah.
And that's where you come into play,
Mhm.
right?
Yeah.
To train those technologists to know TCD. And our systems eliminate a lot of, it just streamlines workflow.
Yeah.
So that's what it is. It's about speeding up the exam, reducing exam time, enhancing workflow, because they are overwhelmed
Yeah.
and they need shortcuts. And our post-processing capabilities really help them.
Yeah. I agree with that. It definitely simplifies the system. I mean, even just working on the system yesterday in the teaching environment with my participants, I was like, this is so much better than what I learned on 20 years
Yes,
ago.
we eliminate the button pushing.
Way
There's less
easier.
to do.
Yeah.
Yeah,
Yeah.
definitely.
And more reliable information.
Sure,
Like, you get really good information.
absolutely.
So, speaking to integrating physiologic into outpatient rather than hospital settings, would you consider that a big driving force behind the Express system, or what exactly made image monitoring decide to take that next step with that system?
Yeah, the reason that we push forward is, again, we had the hospitals asking for a mobile system in the hospital, so they'd have to push a full-size ultrasound and a full-size physiologic, so it's very mobile. But definitely the integration into EMRs and into PACS systems, whichever the facility wants. We're fully integrated into systems like Epic, so
Yeah.
we can go directly into Epic. We have complete DICOM SR or Epic integration where the values will go over individually. So if you have automated reporting package on your system the doctor's using for ultrasound, anything of that nature, this system will go right into it, just like our big system will. Now the Express will do that as well. And typically, when you buy a lower cost product, something that's sub 20, you really sacrifice your quality of accuracy, the capabilities of the system, and your connectivity. The Falcon Express doesn't sacrifice any of
Right.
that for you. And I know Staten's a huge advocate of doing physiologic testing as well as TCD in the office setting. But can you tell us why the cardiologists really should be doing full physiologic testing in their office?
Well, they definitely need diagnostic systems that are more accurate, and we provide that. And of course, our systems are able to integrate with our PACS or their EMR system. And we have several models to accommodate any price point or any configuration. The Express that we see here is just one model, but we have several different models in the Express lineup with different configurations to fit and accommodate any need.
The interesting thing that I find for cardiovascular is cardiologists a lot of times were just doing ABIs, segmentals, and they weren't doing any of the other tests like thoracic outlet, Palmar arch assessment, things of that nature. And I've, through the years, have helped educate a lot of doctors, cardiologists, we get a patient in that's complaining of numbness, tingling in their arm. And so we do an ECG because it's an indicator for cardiac disease. And then they don't have the cardiac disease that we suspect that would cause that arm to be tingling or get numb. So a logical step would be to do an upper arterial and also to do a TOS exam on that patient.
Mm-hmm.
Quite frankly, I would say 90% of cardiologists aren't doing that in their lab. They're doing an ABI. But that's a test that definitely needs to be done.
Mm-hmm.
And frequently that patient would be sent to a neurologist for neuro testing. But the problem is it could be vascular right from the get-go, and we'd be bypassing that. And TOS exam even on the Express takes 5 minutes.
Yeah.
It's a quick assessment. Palmar arch assessment. If we're going to do a radial access on a patient, we should find out if they have a full palmar arch.
Mm-hmm.
Absolutely.
Do they have a patent palmar arch? I know a lot of doctors are doing an Allen's test, but if we're doing an Allen's test, we really should hold that radial compression for at least a minute to be able to see that true blanching.
Yeah.
And I don't know about you, but a lot of the interventionalists that I worked with, a minute is eternity.
Mm-hmm.
15 seconds is still long, but maybe 15. So with the doing a radial access, a study on the system or a radial assessment, it takes 5 minutes, and it's reimbursable under 93923. I believe the reimbursement average is around $120 for that.
Yeah.
So it's a great study for them to do on any patient that we're going to do radial access.
Right. So it improves patient care, it improves revenue.
Right.
And
Decreases
I'm sure
time
that
to treatment.
decreases the time to treatment. And I'm sure the patients are like, my doctor's awesome. He came in, he did this whole study. And doesn't the system, whether it be the Pro or the Express, kind of walk them through what to do? Yeah.
That's the cool thing with the system is that it will walk you through the step-by-step on the screen so that there's no question on what you're supposed to do next. And the neat thing with these tests as well, if you know how to do an ABI, you can learn how to do a palmar arch in a few minutes on the system, because everything, once you learn the touch screen or the remote, everything else is an extension of the ABI, really.
Yeah.
Awesome.
Well, I think that is one of the gaps in the outpatient and even sometimes in the hospital setting, that the clinicians or providers are unaware of the opportunities they have with these physiologic systems. And they just think, well, an ABI, that's all I need to do. But they don't understand there are CPT codes. They can bill for this. They can get a lot more information than just a general, there's disease between here and here. We can be more precise in our diagnosis and decide whether they need to really go on for potentially some intervention, or if they're, to alter the treatment of that patient right then and there. I know as just myself as being a patient, I would rather go to a doctor that has those services there and can maybe in the same time, same visit, find out what's going on, rather than have to go to another site, wait to get in, as we were saying, staff shortages. It takes sometimes months to get in, to get an imaging, exam done.
Right.
So just that in itself of decreasing the time to diagnosis and treatment is huge.
To create a one-stop shop.
Yeah,
Yeah.
exactly.
Yeah, exactly. Yeah, there's nothing worse, and I've experienced this myself, being a patient. You have a symptom, and you go to the doctor. I'm not sure what it is. Let's order a test. And it's 6 months out before you get that test.
Yeah.
So you have that symptom for 6 months, and what's going through your head? The big C. I mean, there's all kinds of things that go through your head. So you've got that mental drain on you that entire time.
Right.
Where if you're at your doctor's office, internal medicine, cardiologist, and we can do a simple physiologic exam on that patient, or like I mentioned, TOS, we can. That's such a quick test and easy to assess. Okay. So and the nice thing is, well, a lot of times the doctors in the past, pre-COVID, were utilizing these systems that did derived pressures on a patient, like this little finger clip, and said that was an ABI. There's a lot of different hoaxes out there that have really, since COVID, people have come to light that are realized, these systems that are, supposedly a system to do ABIs really aren't the way to go.
Mhm.
You want something that's accurate, reproducible. So when you do that referral or that diagnosis that the patient's normal, it's accurate.
Right, right.
Yeah.
Well, and I like, as you highlighted, the fact that, because I can hear a lot of the participants that we've taught in the past, like, how am I supposed to integrate this into my practice? I'm already so busy. But as you said, it doesn't have to be the physician performing these exams. It can be your MA, it can be an administrator, it can be somebody you bring in just to do these exams who you're utilizing for that aspect, have a room set aside and they're doing just this for you. So it's really a lot of different ways you can work it in and make it work for your practice in the exact format that you need it to.
Most definitely. If you look at an internal medicine doctor, and an internal medicine doctor, they see a lot of diabetic patients in the day. So a doctor of internal medicine may say, I only refer out for these twice a month. They should be referring out for more than that, but the reason they're not is because they're not looking hard enough or thinking necessarily about the patients that have PAD to catch it early. And our goal is to catch it when the patient's very early in the disease process, because we can possibly treat the patient from exercise or pharmacologically. So if you have a patient, let's say a diabetic patient, they're 40 years of age, you ask them, how do you do? Are you walking regularly? Patient may be obese, if they're 50, 60 pounds overweight. Are you walking 5,000 steps a day, 10,000 steps a day? They probably don't know. And so then you say, okay, so what I'd like to do is do an ABI, and then you get a baseline. So we can do a baseline with a PVR and ABI and test that patient. If that ABI is normal on our new systems, we have PWV, pulse wave velocity. Is what that does is take 2 points, the arm and an ankle, or an arm and a thigh. And it tells you if there's any slowdown in that flow when you're going from the arm to the distal point. And there are set normal values, and we can do that study in about 2 minutes. It does get you a little bit more reimbursement, about $14 over your ABI that you're doing. But the benefit is, if I do that and I find that patient's PWV is abnormal, I've diagnosed him now with PAD. And now I can have that patient come back every 6 months to a year, do an ABI if it's normal, still great. Do the PWV. If the PWV is getting worse, then I'm going to ask that patient, I need you to start walking.
Yeah.
I need you to lose that weight.
Yeah, you got to be compliant.
Right. I need you to quit smoking. All those things will, if you're giving them that opportunity, at least you're not waiting until I have an ulcer at the side of the leg and then it's too late.
Yeah.
We're
Preventative care.
Preventive care.
Exactly.
Yeah.
Well, and the patient's seeing the data firsthand, so I would think that would motivate them too to make some lifestyle changes. And I think that's really where the bread and butter is you're making lifestyle changes rather than having to do surgical or pharmacological intervention. And that's what your patients want to hear. None of us like to work hard. Like, let's be real. Nobody wants to have to eat the broccoli and go to the gym at 5 a.m. and do all the things you have to do. But when you have something telling you, look, your lifestyle is leading you down this road and you can catch it and know that early, it's going to motivate you more likely in a way than just having your doctor say, you're 20 pounds overweight, you need to lose weight. Like, I don't see that's affecting me. I feel healthy, I feel fine. But when you have that kind of data and they can show you it worsening over time, you're like, oh God, I got to make some changes.
Exactly. And the cool thing with our latest software is we do trending as well. So we can compare that PVR at the ankle. So PVR, of course, tells us the total overall volume of flow in the extremity. If we're increasing collateral circulations, we'll see that increase in the PVR, where we probably won't see it in the ABI. But also with the PWV, we're going to see that improvement in the PWV. And that makes it easier for the doctor if they have that trend saying, here's where we started. Look at your waveform. Then all of a sudden you started really working at it. And now we've got these beautiful waveforms coming through.
It's motivating.
So, motivating. Yeah.
Absolutely. They're seeing improvements.
Right. Like, oh, what I'm doing is working. Okay.
And then they stay on track.
Yeah. Maybe I won't eat that bowl of ice cream tonight.
Then they're committed.
They're
committed to the new
they
lifestyle.
Get a buy-in. Yeah.
That's right. Yeah. And that's what people need. They have to be motivated. And if they can see where they're at and they see it get worse and then they make a change and they see they're getting better and they're probably feeling better too.
Right.
Then that's definitely a motivating factor for them.
That would be something that you're saying that about feeling better. The system has the capability of taking a picture of extremity like toes, feet, whatever we want, so you can compare. I think you're onto something there where it may be beneficial to take a picture of the face,
Yeah.
Yes.
the first time they come in, and then
Mhm.
as they exercise. We all know exercise, people get happier. You get changes in your facial structure, everything if we exercise. So that would be an interesting
That
one
would
to
be.
add to it.
Yeah.
Absolutely.
Yeah.
There's
Or
another.
just feeling better about yourself. You
Right.
just have a different glow,
Right,
right?
right.
Yeah.
Right. And when you're in pain and you're not feeling well,
Mm.
you not only do you show that in your face, but you actually look older too. So,
Oh, most definitely.
so they come back and they're smiling and they look younger. They're like, whoa,
Yeah,
that's
This is
awesome.
working.
yeah.
Doctor's a miracle worker.
Add that to your
Dr.
sales
Jones
tips.
is great. Yeah.
Right.
I'm going to steal that. No.
It's a good one.
Absolutely. All right.
All right. Do you want to move on to the next
Yeah,
question?
let's talk
Sure.
about TCD.
Okay.
And we is that the next one?
Let's go over the test.
Oh, okay.
Yeah. You got that one?
I do. Okay. So, why don't we talk just a little bit about the test on the Falcon that you see on the rise in popularity?
Sure. And some of that I alluded to it a little bit
Yeah,
ago.
right.
And yep, that's a great segue into, yes, that TOS that I mentioned.
Mhm.
For cardiologists, it's imperative that they test those patients that have numbness, tingling in their hands, because they're coming there for that
Right.
problem. Is it heart related or is it not?
Yeah.
So easy to do. The same MA that they maybe have it doing ABIs, segmental studies, diagnostic segmental studies can do can do that exam as well,
Yeah.
the TOS, or that palmar arch assessment before you do that radial access. And radial access has become extremely popular right now
Right.
for cardiac. If you're doing that, you need to do it in your office. Some doctors, like I mentioned, are doing Allen's, but they're doing that at the hospital just before the patient goes in for procedure.
Right.
Mhm.
A little bit late in my eyes when the patient's already there and you're all ready to go. And then, we don't have a good palmar arch. Maybe I shouldn't.
Especially when you're talking about,
And there's a
Yeah.
lot of fistula
Intervention like that.
surgeries too.
yeah.
We have
Exactly.
an excellent
Yeah, the
fistula
hemodialysis access.
protocol on the system. Definitely.
Yeah. I'm actually, in my time working for a vascular surgeon, I was dumbfounded, like negatively surprised by the amount of fistula creations that were done with absolutely zero preoperative testing for inflow and outflow,
Mm.
and how many of them failed. And it's like, this is a person's lifeline,
Right.
and you have to do your due diligence. So
Mm.
I would think if I were sending a patient on for a dialysis fistula creation, whether I was their primary care doctor or their cardiologist, whoever I was, if I knew that that's the stage they were at, and I'm now going to refer them out to a surgeon who can handle that, I would want to perform that testing myself so that I knew it was done and it was done appropriately and accurately, because that's my patient at the end of the day.
Right.
I would
Yeah,
think they would
most definitely.
all feel that way.
Yeah, that's good mention of the fistula, because we do have a great AB fistula steel
Yeah.
protocol on there, where if we're doing it with ultrasound, a lot of times that's a 2-person exam.
Yep.
Mhm.
Where if we do it with the system, 1 person can do it. It's very definitive, very easy, takes 5 minutes
Short
to
and
do.
sweet.
Wow.
Yeah.
Hmm.
And so a lot of people have switched over that. We were asked, because of time restraints and lack of technologists, to find ways to speed up testing.
Okay.
And so that's one of the tests that they said that, it can take 45 minutes to an hour, and it takes 2 technologists many times. Can you streamline this down? We've got it down to less than 15 minutes for 1 person.
Yeah.
Very, very easy
That's
to do.
huge,
Yeah.
Yeah.
especially in the short-staffed facilities that we have.
You're seeing
Right.
40 patients a day.
Right.
Like, yeah, turning them out. Just a little side note to the types of tests that you offer. Can you kind of give our audience that's listening to this, we've got patients, physicians, sonographers, all sorts of different listeners in our audience. Can you just break down, so in the vascular world, a lot of people are like, duplex is the gold standard. We're going to get a duplex. And I think a lot of physicians who maybe don't really know the ins and outs of physiological testing agree with that as well. Can you kind of break down that added component that physiologic testing will bring to that duplex, or be superior than a duplex?
Yeah. A lot of institutions, big institutions, have realized that the first thing that we need to do on a patient with possible lower arterial disease, not diagnosed yet, or maybe diagnosed, is we need to do something quick to decide if we need to do ultrasound. So physiologic is that tool. The physiologic is going to tell you the functional impact of that study.
Yeah.
Where if we're doing a ultrasound, it's going to tell you, hey, I've got, 80% stenotic lesion in the, femoral artery. But how is that affecting the patient?
Right.
You have no way of knowing. You don't know if they've created collaterals. Do we have collaterals to work with that we can build on through exercise programs, things of that nature? So physiologic testing allows you to know the functional impact.
Because the PVR will
Right.
let them know if there's collateral flow.
Right.
Yeah.
Yeah.
And doing the toe waveforms and toe pressures lets us know what the microvascular system is, what the end point, the most distal point on the body is giving us for flow. If I do an ultrasound and I go all the way down to the tibs, I still don't know what's in the toes.
Right.
And by doing a toe waveform and a toe PPG waveform and pressure, I can assess that and know whether I need to do more, look deeper, or go from there. And plus, doing a post-exercise. If a facility will start doing post-exercise, I prefer on a treadmill, so you can bill for it, 93924. But if I have a patient that can't exercise, or maybe I've got an doctor's office, I don't have a treadmill,
Yeah.
do toe raises.
Yep.
And
Very effective.
Yep, very effective, works great. And the system has a protocol in there for you. It'll do the trend, everything for you on that post-exercise.
Yeah.
But the cool thing is you can do it in the same room. Just do your toe raises, lay back down, do your ABI. A facility that'll do post-exercise will find 20% more patients with PAD
Wow.
than if they're not doing
Just at rest.
post-exercise. Right. So if I have a patient, let's say is mild, but has severe leg pain, when I do an ABI, I'm going to have that patient do toe raises.
Yeah.
If I get a patient that gets severe leg pain and I've got a moderate ABI or PVR waveform, then I'm not going to exercise that patient because I've already diagnosed it for my lower arterial. And then I'm going to do an ultrasound, right? I'm going to decide, does this patient need further testing?
Mm-hmm.
But when that patient comes back in, I can do a physiologic exam in 6 months. Has it gotten worse or stayed the same?
Yeah.
If it stayed the same, I don't need to do an ultrasound. There's absolutely zero reason to do that. And that's what hospitals really are looking at right now at the hospital level, is saying, geez, our sonographers are swamped. We don't have enough sonographers. If I can do a physiologic exam in 20 minutes and then let that patient go versus doing an ultrasound and a physiologic exam for an hour and 15 minutes, I think you're going to win out all the time saying physiologic is the way to go.
Right.
Right.
Makes
And
sense.
so yes, that's the thing that we've seen is saving time is everything for everybody, and diagnostically accurately doing it.
Mm.
If I have a diabetic patient that's over the age of 40, do I want to do an ultrasound on that patient? No.
Yeah.
I want, unless that patient has severe symptoms, which in many instances they won't, do an ABI, do a PWV, see if they have disease. If they do, start monitoring them and just track them for years to come if you wish.
Yeah. And as you mentioned, diabetics, those ABIs aren't always so reliable because
Right.
of the calcified vessels. So
Exactly.
again, the physiologic testing will kind of tell that story in this situation where maybe the ABI didn't give it all.
Exactly. And that's where that's one of the problems that I have had with doctors that have been using these inaccurate devices that are, I'm trying not to say any names of products that
Yeah.
that I absolutely despise. The only reason I despise them, I don't mind tests being easy, but if you're going to make a test that's used on a patient, just make sure it's accurate and reproducible. And if you're telling a patient they don't have disease, what happens if they do have disease? In many instances with other devices, it will tell you don't have disease. Imagine being a patient, you had a little bit of a leg pain, cramping when you walk. You go to one of these places that are using one of those devices, and you're told that it's normal. Your ABI is normal or your waveforms are normal.
Yeah.
So then you go home, you've written off that pain. It's just old age. Take an ibuprofen, twice a day, whatever.
Don't change your lifestyle.
Yep, don't change your lifestyle. 5 years later, I got this ulcer on the sore on the side of my leg. I go to the same doc, and they said, put that on. They say, well, no, it's still normal, but I'm going to send you to the vascular lab. Vascular lab, they get there, and all of a sudden it's, wow, you have severe PAD.
Yeah.
This patient went in 5 years prior, could have had it minimal intervention. Now we could be looking at a full bypass. Who knows?
Yeah.
And it's not right. And that's why I get so frustrated with those products that just are not accurate
Right.
and reproducible, they shouldn't be allowed to say that they're billable
Right.
to me.
Yeah.
Well, and that speaks to the provider doing their due diligence as well, rather than purchasing a system based on price alone or, just some limited information without having a full understanding of how you integrate physiologic testing into your practice and when and how you do it and understanding the training aspect of it. They're going to end up just buying whatever's the cheapest. We see that a lot, right?
Right.
They don't like compare system to system. And so if they do their due diligence and really check out multiple systems, then they have the opportunity to learn more and how to most effectively integrate it and then how to utilize that information to best help their patient. So you can't just go by price alone. I mean, that's pretty much anything we do in life, right? If you go with the cheapest price, you may or may not have the best product. But when it comes to patient care, and we're all about improving patient care and improving patient outcomes, and you have to do your due diligence and you have to be willing to invest your time into learning how to utilize that system to the best of your ability so that your patient will benefit from that.
Yeah.
Right.
And the beauty of your system and doing physiologic testing, like you said, with even in an outpatient practice, let's say a cardiologist office, they may have already invested in a higher end system, ultrasound system to do, echoes, obviously. And then they add on doing carotid duplex scans. And then they decide they want to do, peripheral vascular evaluations, DVT, peripheral arterial. And they don't really know much about physiologic testing because they've lived in the world of imaging for a long time. And they put all this money into this high-end system. We're going to get as much out of it as we can. But, I mean, we've both worked in dedicated vascular labs, and doing a lower extremity arterial exam on a patient who has substantial PAD is very time-consuming.
Time-consuming.
And so there's a right and a wrong way to address that particular situation. And that's where physiologic testing comes in. And so educating the provider on the benefits of physiologic testing, the purpose of it, and when and how you do it is really integral into helping them to expand their services that they have, but more importantly, get their patient to a diagnosis and treatment more effectively and efficiently. And so I think that's where that little gap is at, especially in an outpatient type setting.
Yes.
Right.
So
Most definitely.
Yeah. And I think that's what your product will address well is an outpatient setting.
Most definitely. And that's one thing that's unique about the Express, that since we're here today discussing the new system, is all the other units that are sub 20 in that sub $20,000 category were all like pocket op units that then migrated north and just added a few bells and whistles to say, hey, we're worth 10, now we're worth 11, now we're worth 12. We're the only company that really went the other way and had very high-end, built a reputation on having very high-end, high-quality product, and have migrated towards a lower-cost product, but yet keeping the true diagnostic capability and accuracy that our Falcon Pro has had for 14 years.
Yeah, because it's the same probe. They're not losing any quality or technology whatsoever.
Yeah.
And we make our own probes now in-house, which enables us to offer a 2-year warranty replacement.
Oh, that's awesome.
Yeah.
Because everybody drops a probe.
Yeah.
And the nice thing about that is because its price point is great, its accuracy and its ease of use. This is even a great product to integrate into the primary care family practice arena because most of the time these patients are going to their primary care first.
Right.
And that's a service that they can easily integrate in at a low cost point.
Right.
Yes.
And then make a more effective decision and inform their patient about their disease, change their lifestyle, changes that may be necessary, but then if necessary, get them onto the appropriate referral.
Right.
And, it's no longer is it, can't afford to do that. I don't I don't know how to do it. There's an easy solution to that with a system like yours, and then for getting the appropriate training through
Right.
organizations like ours
Most
where we
definitely.
can get them quickly to where they need to be to
Mhm.
integrate that as quickly as possible.
We can't afford not to.
Right, exactly.
No, they can't
Perfect.
afford not to. They're not, the patients aren't getting the care that they need
Right.
and that you are very capable of providing in your office.
And patients are getting smarter.
Yeah, yeah.
Oh, yeah.
So they know
hmm
what
Yeah.
they should be getting and what should be happening. So if
Yeah.
you want to maintain your patients and keep them in your practice, you need to offer these higher levels of services that answer questions. It's really nice to walk in and get an answer.
Most
Yeah.
definitely.
Right.
I love leaving a doctor's appointment going, okay, I feel like I know what's going on now, and I can modify my lifestyle accordingly.
Right.
Right.
Yeah.
Make adjustments.
It's very empowering.
Yep.
All right. Well, I feel like we've exhausted physiologic. No,
Yeah.
there's so much more we could talk
There's-
about,
right.
but maybe we will kind of change tides here. So we've talked a lot about physiologic testing, but you did mention the Dolphin. So can you talk to us a little bit about transcranial Doppler and kind of where we're at in that arena of things, both with system and with technologies?
Sure. I'll let Staten start with that because he
Okay.
is the Dolphin man. He lives in
is.
Florida and
Yep.
his nickname is Dolphin.
Yeah, the
So-
Florida Dolphin
He's
rep.
our Florida
Exactly. Right. The biggest thing that doctors love about the Dolphin system is patient trending, because ultrasound machines do not offer any patient trending whatsoever.
Right.
And with the ultrasound machine, as you know, there's a lot of manual charting. So we eliminate that. We reduce it because we reduce that charting time because it's done in real time.
Right.
So while you're doing the study or the exam on the patient, in the background, the report's being built. It's auto-generated in real time. And that patient trending, especially with vasospasm patients, they're going to be trended for 14 to 21 days. So you can watch your velocities and your means, and you get all the data, and you can track anything that you want. And all those events are customizable. Anything the doctor wants to track, we can do it.
Okay.
Yeah, any Lindengar ratio, anything that he wants. And as far as monitoring for emboli, our system is one of the only system on the market that has a hits counter. And it actually counts not only the hits, but also counts the artifacts. And that's huge because you're able to differentiate the difference between a hit and an artifact.
Okay.
And if a system cannot count artifacts, then that means that it's counting hits as an artifact.
Yeah.
And then guess what? You have the technologist has a lot of work, post-editing, post-track, to make sure to
Clean that
verify that everything indeed is a true hit.
Okay.
So you have to go through a hits analysis. And our Dolphin system is the only system on the market that has a 3-point verification to verify that that is a hit.
Okay.
So you can actually, if there's an artifact or an hit, you can actually click on it and you can dive in and you have 3 points to verify if it's a hit.
Okay.
And you can actually change it. If you disagree with the system, you can manually change it from a hit to an artifact or vice versa.
Awesome.
We also offer bilateral monitoring. So you can monitor the patient's cerebral flow, the MCAs. You can record that monitoring from 30 minutes to an hour and a half, however long you want to monitor the patient. It has an excellent PFO protocol. So 1 out of 4 people, which is 25% of the populace, has a PFO. So the diagnostics for the PFO is excellent. It's second to none. It even grades the PFO for you.
Wow.
So it will count, when you do the injection, then a Valsalva, and then the hit, it'll actually show all the different time durations between the how many seconds between the injection and the Valsalva, and then how much time was it after the Valsalva to the first hit, and how many hits, and it has a timer, and it'll count the hits, and again, it'll count the artifacts, and it records all that.
All of it.
Yeah.
Wow.
So it's very comprehensive, and it saves a lot of time for the sonographer too, because there's a lot of probe power, so to speak, because we're not splitting the power with an image.
Yeah.
So we're able to insunate all those vessels a lot easier.
Yeah, that's why the Dolphin has become number one in the industry, is the 3-point hits analysis that Staten mentioned. All the other systems are 1-point hits analysis, and it's purely based on frequency shift above the background noise of the Doppler.
Okay.
Where we actually, because our sample rate is so high, we're sampling at 5,000 samples per millisecond or greater.
Okay.
The standard was 400 to 600.
Oh.
So by doing that, we can look at a hit and look and see if it's traveling within the blood or if it's just some noise outside of it, which happens frequently if the patient's moving, talking, coughing. And so we can separate those out. And then the other thing with that hits analysis being so accurate, at most places that are doing hits analysis, like monitoring for patients for hits to see if they're throwing any emboli or whether we're doing PFO, we usually save about 15 minutes on the backside in post-editing on the system.
Oh.
When I was working with a Swedish hospital and watching their workflow, we would go from one patient room right to another patient room when we were doing patients that had intracranial stenotic, well, no, it was SAH patients. So these SAH patients, we'd go in, do a study, and then come out. And the cool thing with it, we have memory on the system. On the system, you can actually grab data that you didn't originally see or when actually trying to acquire. So I can flashlight around and then get out of the room quickly because a lot of these patients, they don't want us there, right? They're not in a good spirit. They want us out. So sometimes patients will kick us out in 5 minutes.
Mm-hmm.
A traditional TCD exam takes 30 minutes to do.
Yeah.
So if you know that patient isn't going to let you be there, you flashlight my windows that I have on the patient, and I can go out in the hallway, I can go down to my office, I can go do another patient and then do it later. I can bring up that data and grab my screenshots that I want, my waveforms, to formulate my entire report.
Okay.
And when I was working with them at their workflow, they would do the patient, and then they would go to the next patient to see if we can get in. A lot of times you can't when you're in the OR or ER, right? Neuro ICU. So they would just start working on editing that last patient because you can do complete post-editing on that patient. And when we're able to get in, they put that on pause and go on to do that patient. So, and then doctors on the back end for their post-review and interpretation, because of our DICOM SR or connectivity into Epic, they can have a reporting package that's automated. So instead of spending 10, 15 minutes doing editing, right, dictating, it's all done automatically for them, and they just tweak a few things.
That's incredible.
Yeah, and so, I've got some facilities that are telling me that their total savings is 30 minutes per exam.
Per exam.
Absolutely. I verified that.
That's a whole nother
Yeah.
person's test.
That's right.
Because
Right.
Baptist Medical Center in Jacksonville, the supervisor, she told me as soon as she did a first study, or two, in the ICU, saving her 30 minutes per exam.
Wow.
And I asked her, I wasn't trying to,
Right.
Yeah.
I wasn't, I didn't have any motive. I just said, hey,
Yeah.
tell me, be honest.
Yeah.
What do you think of the workflow? Is it saving you any time? She goes, I love it. Where were you 2 years ago?
Yeah.
30 minutes is a lot.
It's a lot.
That is huge.
Yeah.
Yeah.
A lot of time.
And as he was saying, how the physicians can remote in, they can actually replay the spectrum and they can listen to it. And that they can also listen to the shower of hits. They can do everything remotely as if they were in front of the machine on site.
That's incredible.
And then you have on the advent of our robotic headset
Mm-hmm.
now,
Mhm.
and that's really been expanding. Our software is expanding constantly, so it's enhancing that system's capability. And so if you have somebody that we want to monitor during an intervention, for instance, where the patient may be moving, we can do that. Another thing that I think is really exciting is, during COVID, we were trying to find out why people were having TIAs and having strokes and mini strokes. In many instances, it was, they were moving. And so with our headset, the patient can have the headset on, we can have them walk down a hallway, we can have them do positional changes and monitor that whole time to see, because if you think about it, when we do a carotid ultrasound, what do we usually do if we're doing our right side? We usually have the patient look to the left and up, right?
Yeah.
Open that up so we can see it really nicely. But what happens when that patient looks to the right and hard to the right over this way? Is that causing more of a problem? It sort of makes sense,
Yeah.
right? If you got a garden hose and all of a sudden you move it that way, what happens?
Makes sense.
right?
Yeah.
And so
That's
if a patient's saying, I have dizzy woozies, put them through a range of motion, just like we would TOS,
Yeah.
put them through that range of motion and see if we all of a sudden get a velocity shift and have a problem. And it's so easy. I mean, it's not, it only takes you maybe 5 minutes to hook the patient up and then monitor for 15 minutes. The reimbursement is really good. You get around 240, 250
Oh, wow.
for that 15 minutes.
Yeah.
So it's
The no-brainer.
I
no,
don't know.
yeah, it's a no-brainer. And so when a cardiologist said, "Oh, we don't do TCD." Why don't you
Why?
do TCD?
Yeah.
Yeah, well, we did. I said, "You do carotid ultrasound, don't you?" Well, yeah, we do carotid. Well, the vasculature doesn't stop here. Last I knew,
exactly.
All the way
the
up.
brain. Yeah,
That's
That's
actually where
cerebral
it's really
flow.
important. Get down. Get down. Yeah.
So yeah, the light bulb is finally going on with a lot of people, but it's still not, by any means everybody.
Yeah.
We're still about 10% of the adapters in cardiology, and we need to get the other 90% doing it.
Yeah.
Another incredible feature of the Dolphin, we were talking about the remote access for the physicians. Well, you can manipulate a scan, okay? So what I mean by that, for example, if he's looking at an MCA that we captured at 40,
Mm-hmm.
he doesn't have to, if he wants to see what the morphology or the depth look like at 55 or 50, he can do that.
Yeah.
And he can create multiple scans from one scan.
That's
He doesn't have to
incredible.
reschedule the patient,
Nice.
to get new data.
Right.
He can extract any data that he wants from the data that he already has.
That's amazing.
Yeah. And then the same with any vessel, the MCA, ACA, PCA, they can do the same thing. They can just walk through the depths and they can just look at all the different velocities and morphology with that.
Oh, wow. That's a game changer.
Yeah,
Mhm.
it definitely
I mean,
is.
I remember when I was early in my practice and we had thermal print film,
Oh, yeah.
Oh,
right?
yeah.
And I'd gone up to the neuro ICU and done a patient who was on a vent and they had to take the vent collar off so I could do the carotid and do all this stuff. And I remember I came out of the exam and a patient was kind of destabilizing and they're like, "Are you almost done? You got to get out of here." And so I came out and the neurologist standing right there, he watched pretty much the whole scan. So he knew what had occurred during the scan. And he goes, "All right, well, just go write it up." And I grabbed the pictures off the printer. And for whatever reason, the setting had changed and it printed the same picture over and over. So I didn't have any of the study. And I
Oh my
had
goodness.
nothing to
No.
give him. I was like, "I'm sorry, I can repeat it." No. If I could have gone back, which on ultrasound
Mhm.
systems today, you can go back and
Yeah.
recall.
Sure.
But yeah, to have that capability to go back and recall your images and even to play with the data and extract
Mhm.
more information.
No,
What a
absolutely.
game changer. Yeah.
Yeah.
One of the other things I'd like to highlight a little bit more on the trending
Mhm.
for SIH patients, we're doing those 15 to 21 days. In the past, the technologist would either have to plot it manually, and a TCD exam, we've got, 10, 12 vessels that a lot of times we're tracking.
Right.
And then you want to track the mean, the peak many times. And now we're tracking the pulsatility index because
Yeah.
give us foresight into it, what's going to happen in the near future. So you got 3 measurements on every vessel at multiple depths.
Mhm.
So sometimes we have 50 measurements that we have there. Can you imagine trying to keep track of all that and memorize that?
Right.
Where this system will automatically put the highest velocity in. If you just want to track the highest velocity, it puts it in there for each vessel group and auto plots it. When you're done with that exam, there's no more work for you unless you want to.
Right.
It does all that for you.
Oh, that's great.
And your patient outcomes are way better too.
Yeah. Yeah. The information you're walking away with,
Right.
much more robust. Briefly, we were talking yesterday a little bit, and you had mentioned back to the PFO correlation versus, between migraines with auras and the PFO. Can you kind of fill our listeners in on that?
Sure. It was interesting for me a couple of weeks ago. I was talking with a neurointensivist, and the doctor told me that, he was interested in getting a system for PFO for his office. And I said, "Oh, that's, a lot of times we don't get that specific
Right.
request from a neurointensivist. A lot of times they want to do other things, but not necessarily PFO." And I said, "Oh, that's interesting. We do that completely. We do it the best in the industry. what piqued your interest in doing PFO? And he said, from what I've been seeing in my own patient base, that 100% of the women that have migraines with aura have a PFO. And he said it's very common in men as well, but women tend to have more migraines with aura in his practice. And so he said 100%, and that's why he wanted to get the system for his office. And I can't say that it's 100% at all. That was the first I'd ever heard of it, but it makes sense if, because what we know about PFO and when they open on patients, and, we know it can happen with stress, exercise, bearing down, coughing. And so that it all makes sense. And if you think of the young patients that were having strokes and mini strokes, and at the high population they did during COVID, why was that in young patients and not necessarily because young patients we know they have PFO, 25% of them do. Well, it's probably because a lot of them were working through it when they got COVID, and they would cough. When you cough, you're doing a Valsalva, you're opening that up. And if there's anything in any emboli that COVID is causing, because COVID had a clotting disorder associated with it,
Oh my goodness.
you got a straight line to the brain.
The brain.
So it makes perfect sense.
Right.
So, a lot of doctors that in the past that were telling me that, I know I've got COVID, I've got PFO patients, but what am I going to do with it? I'm not going to close everybody.
No, but it's risk factor mitigation.
Exactly. If you have a clotting disorder, you should know that you have that risk.
Right.
Because if you have that emboli in your leg, I should know that I have a PFO so that I know I'm at higher risk. Maybe instead of just saying go home, you're going to be put in the hospital.
Right. Empower your patient to take care of themselves and to talk to their providers who maybe don't know they have a PFO.
Right. So I can't say that enough. 25% of the populace has a PFO.
That's one of us.
Right. It's one of us.
Not me. I honestly don't know. You're going to have to bring the Dolphin, and we're going to have to screen our whole entire staff. I need to know which 1 in 4 is it.
Oh my gosh.
It's very interesting. There was
very interesting.
small hospital up in Michigan, and they tested 6 people, 2 patients, 4 staff members. Okay. 2 of the staff members did have migraines, but they had no clue why. The 2 other patients had migraines as well. Well, the 2 patients had PFO, but 2 of the other volunteers, staff members, had PFO as well. Both of them had migraines. Then 2 were normal. So out of 6 people tested, 4 had PFO out of that group.
And out of those 4, all of them were experiencing migraines.
Right. Yeah.
But I don't have any migraines, so I'm good.
Yeah, I'm good. I'm good as well.
I don't really get migraines either. Do you get migraines?
Do you get migraines?
Not anymore.
No.
Used to.
Maybe you closed your PFO.
Maybe I did.
Superwoman over
Yeah.
here.
Should just concentrate. Close,
Right.
close.
Be gone.
You. That's good information.
It
Thanks for
is.
sharing
Yes,
that.
it's very
Yeah.
interesting. It's good for the public too. Like she said, we have patients who listen to our podcast. So, just being empowered with that knowledge is interesting. In fact, one of our models that we were scanning for an echo, we picked up a PFO on him.
Really?
And he had previously had a stroke.
Oh.
Yeah.
And I said, oh, that's interesting. Did they indicate whether that might have been a source of your stroke, And he said, no, I didn't even know I had it. And I said, well, I don't know if you're a scuba diver, but you definitely don't want to go scuba diving. And he goes, really? He goes, they did mention that, but they didn't say why. And so, it's like the knowledge of it's important for the provider to, educate their patients as to what they have and what they should or should not do and why, So we see that all the time. We find things on people but it's just one case right there. So there's a lot of people walking around with PFOs.
Right.
They have no idea.
And the other thing that we see is people are still doing TEE first before they do it with TCD. And for the life of me, I don't know why.
Right.
Because TCD, we can do it in 15, 20 minutes, outpatient procedure.
Right.
One technologist can do the whole test from start to finish. And our sensitivity, as far as finding them, is not 96, 97% sensitivity. If you look at TEE or TTE, if you look at either method, they're in the 70s. So if you're going to diagnose a patient with a problem, do it with the most sensitive device, number one. But then if you want to get more specific, okay, do echo, do everything. But definitely if you're looking for a PFO, you have to do it with a TCD system. And I frankly think that Dolphin is the best because everybody tells it's the best. And so that's why we get the accuracy we get.
Right. And it's not invasive.
Right.
Like in order to get a PFO readout, sometimes you'll have to use bubbles or,
Right.
right?
Well, we do bubble studies. So we will do
Okay.
the injection, you do but it's just a simple tricock and doing an IV, but we're not invasive going down the throat.
Right.
We're not sedating the patient.
Right.
We're not doing anything.
Oh,
Big difference.
that's a huge difference.
I've had patients when I did a PFO study with TCD and say, you know, they hear the shower come through, you know, and then they'll say, can you give me the results? And of course you say, no, I can't. Your doctor will give you the results. Can you tell me this? Is it as accurate as that other test they did to me? And you say, what did they do? It's god-awful study that they put this thing down my throat. It was horrible. And I'll say, yeah, it's as accurate when it's actually more, more accurate.
Yeah.
You hold back
Interesting.
there.
Yeah, I do. I do it because I don't want to get anybody in trouble.
Good
you
for
know?
you.
Yeah. True.
You're very disciplined.
Yeah. Well, we've talked about a lot of things, and I think probably the last question, we've kind of touched on this already, but as far as any obstacles that you've seen or are seeing that would impact future growth of physiologic vascular testing or transcranial Doppler, we know education is a big obstacle there.
Especially for TCD.
Yes.
Yeah.
Exactly. So, but education, with obviously we have plenty of resources here. There's plenty of resources available to get hands-on training. You definitely want to get your hands-on skills training, but in conjunction with that, do you have any other obstacles? You know,
well, as we mentioned earlier, the number of technologists, people that aren't in the field, and that's why with physiologic, not TCD, you know, we're seeing a lot of MAs that could actually be trained to do physiologic, but they need to have a professional trainer train them. Because as we did a video earlier today, there are a lot of different nuances to get the best out of it. And unfortunately, a lot of doctors think that ABI, that's what I'm going to interpret. Now, ABI is and any system is your least sensitive modality for PAD. It came out a long time ago because it was pocket dops and people were trying to do it cheaply and and yes, it was a good thing to do to make awareness, but it's not accurate. That really, if I had waveform to go by, I would like PVR. I prefer to have a PVR and Doppler because the two together tell me the full story. The PVR is going to tell me the collateralized circulation. The Doppler is going to tell me the focalized situation in that vessel. But then the ABI, if it's accurate, and I mean accurate because of calcified vessels, things, edema, things of that nature can cause it. But if it's accurate, yes, that goes hand in hand. And then taking a toe waveform and toe pressure tells me what the microvascular system is doing. So our dilemma is getting that across to physicians because so many, like in the beginning, you said they just want the cheapest. Well, you get the cheapest, you're going to get poor outcomes and you're missing patients. Don't do your research. Look at systems, think it through and think that, you know, this thing I put in my finger and say it's a derived ABI really is not possible. As well as I'd love to think that tricorder thing where I can hold it and wave it and oh, you got a neural problem, it's not available. Believe me, if it was, we would take it on for sure, but but it's not available. So doing it the accurate way, that's our boundary for us for growth is because people are buying those cheap things that they think will make them, you know, it will do it accurately. There's no pill that's going to make you skinny. There's no physiologic system that is going to put on your finger and be able to do a study accurately.
Yeah.
Good point.
Those are all good points. It's very true. There's no easy button.
That's right.
No.
We all wish that
We all want
easy
one,
way.
but it doesn't exist. And if it does, it probably comes with more risks and drawbacks than it's worth.
That's
Most definitely. And then like Staten said, with the Dolphin, it's purely people that are trained in it. People that
Yeah.
are trained in TCD typically will get 20% more, compensation than a technologist that doesn't do TCD, and they're extremely high demand.
Absolutely.
We've got a ton of doctors that tell us we want to monitor in the OR.
Yeah.
We can't. We gave them the robot now so they can monitor easily, but we still need technologists that can go in there, set it up, and then they can pass it off to the anesthesiologist. But it needs that initial setup to know what they're doing, and we just don't have enough technologists.
Right.
Yeah.
And so hopefully, I know you're in contact with all the schools on a regular basis.
Right.
Hopefully we can get that across to the schools that they need to have TCD in their curriculum.
Yeah.
I would say 20% have TCD in their curriculum, and the other 80% do not have TCD in their curriculum. They may have it where they go spend a day at a hospital that has TCD.
It's
That's
the
not in
same.
your
Yeah.
That's not in your curriculum.
Yeah.
Right.
Yeah. And it's
Exactly.
easy to integrate. I mean, it's not a difficult thing, especially
Right.
the educator program that we offer. They could easily integrate it, through
Right.
our curriculum. So
Right. We have an excellent comprehensive TCD online course.
Yeah.
You do.
Very
It's-
easy
it's-
to integrate into a curriculum.
Yeah.
It's fantastic. And then, if they're looking for physiologic and interested in expanded TCD, we have combo systems so they can do TCD and physiologic on the same system.
yeah.
And that really works beautifully in small hospitals or in education department, because in the education, typically you're doing segments on the patients, right?
Right.
You're doing lower arterial training for a month or what have you.
Mhm.
Then you move on to the end,
Yeah.
each zone. So that way you're never using that physiologic at the same time you are TCD, would
Right.
be doing TCD anyways.
Yeah. That's a good point for education.
Yeah.
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 Oh, lots of good things
Yeah.
for everybody to think about.
Right. And our sonographers, that's a tip for you. You want to move up the ladder in your career, expand your skill set.
Yeah.
There's a shortage of vascular sonographers who know how to do TCD.
Yes,
so
we need
Uh-huh.
TCD sonographers back.
Come take a course
So-
with us. We'll
That's
teach
right.
you everything you need to know.
Yes,
Yeah.
absolutely.
Yeah. And it's fun. It's a fun modality to practice
Mhm.
on patients. It's
Yeah.
a new challenge because you get burnt out of doing
Oh, yeah.
lower arterial duplex and carotids all day.
And
It'd be nice to do something different.
what's easier on your body? Yeah, doing
Right.
venous work, pressing hard,
No.
doing the AAA scans on those patients with a big belly, or just up here, a little probe, just moving a probe.
Yeah.
So much easier on your body.
Yeah. Or setting something up
point.
for the OR for monitoring.
Right.
Sure.
And
Like, what a fun job that would be.
Yeah. It's very interesting sitting in. Yeah.
Yeah.
Yeah. Our anesthesiologists
Spice
are
it
gonna
up
be
a
like,
little
yes,
bit.
please.
Learn
Yeah.
something new.
Yeah.
Yeah.
Learn something new.
You always got to
Well,
learn something new.
Any other questions you have?
I do not. I think we've covered a lot of information here. Yeah. Good
Anything
stuff.
you guys want to add before we close things out?
Yeah, the only thing I would personally add is, again, thank you for having us here. It's a pleasure to work with you and let your students utilize our equipment to learn how to do the latest and greatest in physiologic and TCD.
Yeah.
And I really appreciate your education program in TCD and physiologic, because you enlighten a lot of different aspects of it in your abilities here.
Yeah.
You've got such a knowledgeable team put together. It's amazing what you've created.
Super
Yeah.
sharp.
Yeah.
Thanks.
Yeah.
Well,
Appreciate
thank you
that.
so
Yeah.
much.
And all I would like to say to the sonographers and the technologists listening, learn TCD. We need you. The hospitals need you. There's plenty of opportunities in the field.
Yeah. I'm going to make sure I share that. I'm in a couple sonography groups and they are saying, I'm having a hard time finding a job, or I'm feeling burnt out. I want to change. So
Yeah,
I will
TCD's the way.
be sure
We
to
got the supply and the
mention that.
demand is there.
Yeah.
tag our
Yeah.
podcast.
Absolutely.
Yeah.
They can listen and come do a class.
Yes.
That'd be great.
For sure.
They can learn on the Dolphin.
That's
Yeah.
right.
Yeah.
We'll bring it out. Yeah, I'm
I'll be
telling
here
you guys,
personally. I'll be here personally.
Staten is always
man.
here. I call him. I say, hey, I got a class. He's like, I'll be there.
Yeah, absolutely.
That's great.
We
Yeah,
really
we
appreciate you
definitely-
guys.
Yeah, you're
Yeah.
welcome.
Yeah. All right.
Very
Well, it's been a
much so.
great conversation. Thank you, both of you, for being here with us and discussing the benefits of the physiologic and the transcranial duplex and Doppler testing. We really appreciate your feedback, your input, and like we said, your continued support. So thank you so much for being here.
Yes.
Thank you.
Thank you very much. As she said, we greatly appreciate your support and enjoy working with you guys.
Yeah.
And we also want to thank all of our listeners for
you
joining us
guys.
today. We're happy that you're here. Be sure to subscribe to the Sonography Lounge and also follow us on social media so you don't miss another event that we have offered.
Yeah.
So have a great day and happy scanning.
Happy scanning.
Happy scanning.
Happy scanning.
Thanks for listening to the Sonography Lounge. Don't forget, if you like this episode, please subscribe and leave us a review on iTunes, Spotify, or wherever you get your podcasts. You can also find us on Instagram at Sonography Lounge and Twitter at SonographyLNG. If you have any questions, comments, or topic suggestions, feel free to send an email to us at sonographylounge@gmail.com. Have a great week and scan, scan, scan.